Well, I think we can start. Maybe people are still joining in the coming minutes. It's a pleasure to meet you all on behalf of the SciUp Nutrition Network and to have our educational session from April. Well, one short announcement from the group. The SciUp conference will be in Amsterdam in this year, and I think the submission is already closed for abstracts, but we as a group also organize a special nutrition research forum the day after SciUp on October 24th. People will have received already information about it, or otherwise it will come by reminders to you, but please feel free to join us over there as well. And for today we have a very nice talk about exercise. It's a pleasure to have Andres Marmol-Perez in the meeting. He's a postdoctoral research fellow at the University of Granada in Spain, but also a Fulbright Scholar at St. Jude. His research focuses on physical activity in childhood cancer, but specifically after treatment, and he will share his work today, and maybe you will have some more introductions about yourself, Andres, but please feel free to add on that. Thanks for being here, and if people want to ask questions, you can pull them in the chat or ask live after the session. So the floor is yours.
Thank you. Let me just share the screen. Okay, perfect. Can you confirm that you are watching the right screen, please?
Yes. Yeah, perfect.
Okay, perfect. Okay, so thank you very much for the kind introduction. And also thank you to the SciUp Nutrition Network Committee for inviting me to this educational session. It's a big pleasure for me to be here. In today's webinar, I'll show you the different results that we have obtained in the studies that we have conducted in childhood cancer patients after treatment within the iBoneFit project that I will talk more about soon. Please don't hesitate to ask any question during or after the presentation. Nowadays, pediatric cancer, as you know, is still considered as one of the leading causes of death in children. For those diagnosed before the age of 14, pediatric cancer is the second leading cause of death, while for those diagnosed between the ages of 15 and 19, it is the fourth leading cause. In Spain, in 2022, 957 new cases were diagnosed in children and 134 in adolescents. Pediatric cancer is considered a rare disease due to its relative low incidence. However, it is important to highlight that the number of new cases has increased in recent years, with leukemia, lymphomas, and nervous system tumors being the most common. Thanks to the progressive advances in personalized medicine in recent years, the 5-year survival rate for pediatric cancer has been increasing in Spain, reaching an 82%. Nevertheless, many of those who survive suffer short, medium, and long-term health-related complications that need to be considered during survivorship care. Low bone mineral density, defined as a Z score below -1 compared to healthy reference population, has been diagnosed in up to 2/3 of non-hematological cancer, in cancer survivors, and up to half of the hematological cancer survivors. After overcoming pediatric cancer, bone mass does not always recover, and the gain of peak bone mass does not occur. This is caused due to different direct factors, such as the disease itself and the osteotoxic anti-cancer treatment, and indirect factors, such as the deficiency in calcium and vitamin D intake and the long periods of immobilization that lead to a reduction in physical activity levels. Bone development in healthy population progresses during childhood, peaks in adolescence, and gradually declines in adulthood. During the second day of life, up to 95% of the total bone mass is acquired, and therefore the failure to achieve sufficient bone mass during this stage can result in the early development of osteopenia or osteoporosis early during adulthood. However, bone remodeling can be stimulated by external mechanical loadings, for example, during high-impact physical activities. This adaptation occurs through a dynamic process of bone resorption, the breakdown of bone tissue, and bone formation, the building of new bone tissue. In healthy children and adolescents, upper and lower body muscle strength has been associated with higher levels of bone mineral content and density. Also in adults, survivors of childhood cancer, similar results have been found. Therefore, increasing the muscle strength may be associated with better bone health in this population before the age of 18. The International Physical Activity Guidelines for childhood cancer survivors highlight the importance of engaging in at least 70 minutes of moderate to vigorous physical activity every single day and limited sedentary behavior in this population. Previous studies have shown significant correlation between self-reported physical activity levels and, for example, lumbar spine bone health. However, most childhood cancer survivors don't meet this recommendation even year after completed treatment. Therefore, this population doesn't usually receive the osteogenic benefits of high-impact exercise, and therefore there is a need to investigate whether this type of intervention could improve the bone health of childhood cancer survivors. For this reason, some non-pharmacological and pharmacological strategies are emerging to improve bone health in this population. For example, the use of bisphosphonates directly reduce bone resorption by decreasing osteoclast recruitment and indirectly stimulating osteoblasts. However, it requires careful and frequent monitoring, as this medication can cause potential side effects such as abdominal pain and vomiting, among others. On the other hand, a previous systematic review has shown in healthy children that plyometric jump training leads to improvements in bone mineral content and density. These findings suggest that a similar osteogenic benefit could be observed in childhood cancer survivors if they follow the appropriate dietary advice to ensure adequate vitamin D and calcium intake. To answer this question, we conducted a systematic review and meta-analysis to investigate the effectiveness of previous exercise intervention on bone health in children and adolescents with cancer during and after oncological treatment. As we expected, we didn't find a significant pull effect of the intervention on bone health during nor after treatment in this population. The main reasons may have been because most of the interventions were not specifically designed to improve bone health. They just included the outcome because DEXA or other methods were included. Also, the duration and the exercise types may have not been the most appropriate to improve bone health. Therefore, we decided to implement the IBONFIT randomized control trial, considering previous limitations to analyze if a 9-month bone strengthening, specifically exercise intervention, could improve bone health. This randomized control trial was conducted in the city of Granada, thanks to the participation of the University Hospital Virgen de las Nieves and Reina Sofía. In total, 116 young childhood cancer survivors participated in the study and were randomized to the intervention group and to the control group with 58 participants each group. The evaluation were conducted before and after 9 months of the intervention. Due to the restriction caused by the COVID-19 pandemic, recruitment was conducted in 2 waves. The first from October 2020 to November 2021, and the second one from December 2021 to January 2023. This project included children and adolescents who survived cancer between 6 and 18 years old, diagnosed as late 1 year previously, and who had received radiation and/or chemotherapy. The exercise intervention that we implemented will be explained after covering the results from the cross-sectional study that we performed. In this cross-sectional study that I'm going to present next, upper body muscle strength was assessed using the hand grip test, and lower body muscle strength was assessed using the standing long jump test. The movement behavior were evaluated through accelerometry. The past osteogenic physical activity was assessed using a questionnaire specifically developed for this purpose. Sex was self-reported. The years since the peak growth velocity were calculated following the equation published by Moore in 2015. The time since the end of the treatment and the exposure to radiotherapy were collected from the medical reports. And finally, lean and fat mass were assessed through dual densitometry. Using the same device, bone mineral content and density were also evaluated from the total body less head, total hip and femoral neck, and lumbar spine. In addition, using the hip structural analysis software, 3 variables were calculated from the geometry of the nervous region of the femoral neck, the cross-sectional area, the cross-sectional moment of inertia, and the section modulus. And finally, the trabecular bone score of the lumbar spine was also calculated. The first study that we published was aimed to provide novel insights into the contribution of independent predictors to bone parameters in young pediatric cancer survivors. Multiple linear regression were displayed using radar plots, as you can see. This two-dimensional figure allows us to visually identify which predictors variables are the most strongly associated with a dependent variable. The results show that the region-specific limb mass was consistently the strongest positive determinant of each of the bone parameters evaluated. For the radar plot on the left, showing total body bone mineral density, in addition to limb mass, years from the peak high velocity were also positive determinants. For lumbar spine bone mineral density, sex was also a positive determinant. For total hip bone mineral density, time since the end of the treatment and past osteogenic physical activity were also positive determinants. For the femoral neck, time since the end of treatment was again a positive determinant. Finally, for the leg bone mineral density, years from the peak high velocity were as well a positive determinant. And for the arms, the years from the peak high velocity, fat mass, and past osteogenic physical activity were positive determinants. So in conclusion, region-specific limb mass is consistently the most important positive determinant for bone parameters. Year from peak high velocity and the time from treatment completion are also important determinants for the bone mineral density and the hip structural analysis parameters. The second study had the objective of investigating the role of limb mass in the association of a very common central behavior such as TV watching time with the bone parameters, and also to examine whether having a high limb mass would attenuate the negative association of watching television more than 1 hour per day with the bone parameters. Television viewing time were categorized into 3 categories: no television viewing, less than 1 hour, and more than 1 hour per day. Note that these analyses were conducted separately on prepubertal and peri-postpubertal survivors due to the interaction between the year from peak high velocity observed for these variables. Taking the group that didn't watch any television as a reference, models 1 and 2 adjusted for sex, time since the end of treatment, and radiotherapy indicated that watching television for more than 1 hour per day was negatively associated with lower score on most bone parameters, but only in peri-postpubertal survivors. When these analyses were adjusted for limb mass variables, model 3 indicated that this significant association disappeared, except for femoral neck and the trabecular bone score, demonstrating the potential protective role of limb mass. In this sense, selecting only those who watch television equal or more than 1 hour per day, we observed that those who had a limb mass above the median had significantly higher bone mineral density in all regions, compared to those who had a limb mass below the median. These results were similar for the hip geometry variables, but not for the trabecular bone score. This study indicated that TV watching time is negatively associated with most bone parameters in peri-postpubertal survival, but this association seems to be dependent on limb mass. Noteworthy, survivors watching television more than an hour per day and with high limb mass present higher bone parameters than those who have a low limb mass. The third study was aimed to examine the association of the so-called 24-hour movement behaviors with age, sex, and race-specific bone mineral density parameters at clinical sites in prepubertal and peri-postpubertal cancer survivors using the novel compositional data analysis. This type of analysis allows us to analyze all movement behaviors simultaneously over a 24-hour period. It should also be noted that from now on, the bone parameters used were calculated in comparison with a healthy reference population of children of the same age, sex, and race from the bone mineral density childhood study. The results in the figures on the left panel show the association of increasing one behavior and proportionally reducing the others, while the figures in the right panel will show the association of increasing one behavior, but in this case proportionally reducing only another one. These findings indicate that increasing moderate to weak physical activity while proportionally reducing the other behaviors is associated with a better bone health of the total body, total hip, lumbar spine, only in prepubertal survivor in color blue. The results of the figures in the panel on the right indicate similar results when increasing moderate to low physical activity and proportionally reducing light physical activity individually, as well reducing individually sedentary behaviors and also reducing individually sleep time, maintaining the rest behaviors constant. The findings from the figures in the left panel indicate that increasing, in this case, light physical activity while reducing the other behaviors is associated with a better bone health in all regions, only in peri-postpubertal survivors, in orange. However, the results in the figures in the right panel indicate that increasing light physical activity while reducing moderate to low physical activity is not associated with a better bone health in any of the regions in this group. In fact, in the prepubertal survivors group, increasing light physical activity while proportionally reducing moderate to low physical activity individually is associated with worse bone health in the total body, total hip, and lumbar spine. Furthermore, increasing light physical activity while reducing sedentary behaviors is associated with a better bone health at total body and femoral neck in the peripubertal group. And when sleep time alone is proportionally reduced, it is also associated with a better bone health across all regions in this subgroup. In this observational study, the predicted association of moderate to physical activity with higher bone mineral density are significant at most sized in prepubertal young pediatric cancer survivors. In the another group, in peri-postpubertal survivors with low moderate to physical activity levels, light physical activity is significantly associated with higher bone mineral density levels at all sites. The fourth study had the objective of investigating the prevalence of upper and lower body muscle strength deficits in young pediatric cancer survivors compared to age and sex-specific international reference data, and also to examine the association of upper and lower body muscle strength with age, sex, and race-specific bone mineral density test score at total body, total hip, femoral neck, and lumbar spine. In our sample, more than half of those survivors had muscle strength deficits, both upper body and lower body, defined by a decile of 2 or lower. Our results showed that upper body muscle strength deficits, decile 1 and 2 on the x-axis, were associated with worse bone health in every region. Also, our results show that lower body muscle strength deficits were associated with a poorer bone health, again in all regions. To assess the risk of low bone mineral density, the cutoff point that we use, as well as in previous study, was a set score of -1. A reduction in the upper body muscle strength by each decile in the panel A was associated with a 30 to 95% increased risk of low bone mineral density. And a reduction in the lower body muscle strength by each decile in the panel B was associated with a 35 to 70% increased risk of low bone mineral density, except for lumbar spine. In conclusion, this study identifies both upper and lower body muscle strength deficits and the association of such deficits with bone mineral density. The fifth study was aimed to evaluate bone mineral density differences according to the sarcopenia status of our population, and also to examine the risk of the low bone mineral density in our population with sarcopenia confirmed and probable. To identify survivors with probable or confirmed sarcopenia, we follow the algorithm proposed by the European Working Group on Older Adults, although the cutoff points for each category were specific to the pediatric population. Survivors who didn't have upper body muscle strength deficits were considered to have no sarcopenia. Among those who had upper body muscle strength deficits, survivors who didn't have a low appendicular limb mass index were considered to have probable sarcopenia. But if, in addition, they had a low appendicular limb mass index, were considered to have sarcopenia confirmed. In our sample, more than 1/3 of survivors show sarcopenia confirmed, and interestingly, this proportion was slightly lower in girls than in boys. Survivors with confirmed sarcopenia, always in color red, had lower bone mineral density in both regions, in the total hip and the femoral neck, compared to those without sarcopenia, always in color green. Furthermore, compared to those with sarcopenia probable, in color orange, survivors with confirmed sarcopenia had lower bone mineral density in both regions. Survivors with confirmed sarcopenia also had lower total body lumbar spine bone mineral density compared to those without sarcopenia in color green, and in addition, compared to those with probable sarcopenia, survivors with sarcopenia confirmed had lower total body bone mineral density. Compared with those without sarcopenia, survivors with confirmed sarcopenia had an increased risk of low bone mineral density in all regions except for lumbar spine. And again, compared with those with sarcopenia probable, survivors with sarcopenia confirmed had a higher risk of low total body bone mineral density. So this study showed that sarcopenia seems to be prevalent in young pediatric cancer survivors and is associated with a higher risk of low bone mineral density. These results suggest that sarcopenia detection in this population at early stages after treatment could help survivors to be screened for low bone mineral density. And the final study had the objective of investigating the effects of the 9-month online resistant exercise intervention on the femoral neck bone mineral density as the primary outcome, and also other markers of bone health, including bone mineral density and bone mineral content as secondary outcomes in young pediatric cancer survivors. The total intervention volume was 7,296 squat or jumps across 136 sessions over 9 months, with each session lasting from 10 to 20 minutes. The intensity progressively increased in volume from 3 to 4 sets, from 10 to 20 repetitions, and from 3 to 4 sessions per week within the intervention phases. The intervention was divided into 3 phases of varying duration and impact loads. The first phase corresponded to the first 8 weeks of the intervention, and the survivors performed squats with their own body weight. The second phase lasted 12 weeks, and the survivors performed squat jumps. And finally, the third phase was the longest of the intervention with 16 weeks, and the survivors performed counter movement jumps. Of the 196 survivors contacted, 116 accepted, resulting in a recruitment rate of 59.2%. In the exercise group, 13 survivors didn't complete the post-intervention bone health assessment, and 9 didn't achieve the minimum compliance requirement, which was 70% of all sessions. In the control group, 4 survivors didn't complete the post-intervention bone health assessment. The mean adherence in the exercise group was 92.3% in the first phase, 87.7% in the second phase, and 69.4% in the third phase, with a mean overall adherence of 83.1%. All 116 survivors were included in the intention to treat analysis that I will present next. The per protocol results were included in the supplementary material and will not be shown in this presentation. The intervention effects were analyzed using longitudinal mixed models, assuming similar baseline means between groups. The models included fixed factors such as time, pre or post intervention, group, exercise on control, and a single random factor, such as the participants' ID. There were no between group differences in either femoral neck bone mineral density or content. However, we did observe significant differences between groups for the total hip bone mineral content with an effect size of 0.32 and a near significant differences for total hip bone mineral density with an effect size of 0.35. Unlike bone mineral content, bone mineral density is a volumetric measure that also takes into account the area assessed, and therefore this could explain the greater effects observed on total hip bone mineral content. The findings of this RCT show that a 9-month online resistant exercise intervention of high impact loading does not increase femoral neck bone mineral density, yet it induces improvements at the hip region in childhood cancer survivors. During a sensitive period of life, such as childhood, for bone remodeling, these improvements may contribute to reducing the risk of osteopenia or osteoporosis at this site later in life. Despite significant advances in pediatric oncology, exercise, and bone health area, many questions remain unanswered. This could advance current knowledge of the effects of exercise on bone health, laying the groundwork for individualized strategies and guidelines, tailored specifically to each patient needs. Future research should focus on the following areas. It is necessary to determine whether the combination of exercise program and pharmacological intervention are more effective in preventing bone loss in children and adolescents during cancer and or improving bone health after completing treatment. To determine whether the improvements in bone health are maintained over time after the session, the finishing of the high impact resistant exercise intervention. Also to discover which demographics, treatments, lifestyle factors, and health-related conditions may improve the adherence to long-term exercise programs to improve bone health. To better understand the potential sex-specific differences in the effects of a high-impact resistant exercise intervention on bone health. And finally, to the creation of age and sex-specific reference values for the pediatric population using, for example, high-resolution peripheral quantitative computed tomography data, hip densitometry-derived structural analysis, and lumbar spine trioculum bore scoring will surely address their clinical significance. Finally, I would like to recognize the huge involvement and help from all the members of the iBoneFit project and the funding agencies that have supported the creation of this study. In addition, I also want to acknowledge the participation and effort of all children, adolescents, along with their parents, because without them, it would have been totally impossible. Thank you very much for your attention, and I'm more than happy to take any question.
Thank you, Andres, for your very nice presentation. I'm impressed by all the different kind of studies and evidence you talked through, so that's very nice. I'm wondering if there are any questions from the audience. Please, you can unmute yourself or put them in the chat. Otherwise, I can start with one. You were talking like in one of the last slides about synergistic effects, like from probably medicine or something else. But I was wondering, what do you think about, or what was probably known in your iBoneFit study about nutrition? Did you ask specifically about that, and how would you see synergistic effects in future studies, probably on that aspect?
Yeah, Actually, I forgot to mention, I mean, it wasn't an intervention as such, the nutrition component, but we, at the beginning of the intervention, before they started to do the exercise, both groups, the exercise group and the control group, received dietary advice to meet the requirement for the calcium intake and the vitamin D exposure, so that we could control in both groups that they somehow they were meeting the guidelines. But as you said, I think it's quite interesting to investigate this synergistic effect of implementing the exercise component as well as the nutritional component to ensure, because we did double check if they were meeting exactly the requirement for the calcium and also the vitamin D. So I think that would be an interesting idea.
And did you previously worked also on like protein or protein supplements in combination with your exercise?
No, not at all, not at all, not at all. But in one study that we are currently finishing, looking at not the effects on bone health, but on the muscle health of the population, we have found some studies that have been performed in St. Jude, and they didn't find differences of the protein supplementation on for example, the lean mass. So both groups, resistant training and also the resistant training plus the protein supplementation, didn't show big differences. So there's somehow there is a resistance to the anabolic muscle protein that something is going on for sure.
Yeah, that might be probably different for patients and survivors. I don't know, but
Yeah.
yeah, interesting. Well, I have another question. I was also well, like one of the first studies you were talking about watching television and the association between bone mineral density. Is such an association the same for like iPhone or like a phone use or something like that? I can imagine that. Well, maybe 20 years ago, television watching television was like
Yeah.
hot happening for teenagers and pubertal kids. But maybe nowadays it's more like using your phone. I don't know. How is that?
Yeah. You're right. You're right. We have had many discussions about this because that's a great question. At first, we also recorded, we also collected information about for example, the time that they spent using video games, the computer. But the things that we thought not to include them as well as the mobile time, because not everyone, we think that not every child or adolescent is able to afford to have a mobile phone. So, for example, we have seen that they didn't spend time on with the mobile phone, but just because they didn't have it. So we thought that it was more possible to have one television per family than one mobile phone per child or adolescent to investigate this central common behavior with association with bone health. But it's true. It's totally true that nowadays, for example, mobile phones could have as well a similar impact.
Yeah. It was an interesting fact.
Yeah.
And the same, or at least the last question I had, is also regarding sarcopenia. You mentioned like that girls were less likely to be sarcopenic in survivorship. Is that something you already knew, or how could that work?
That was I think a striking finding that we had, because we couldn't at least find much study on sarcopenia in this population. I think there was only a previous one, but just with 20 patients. So it was a bit surprising. Some possibilities could be that, for example, the cutoff points for boys are higher than for girls, and even during childhood and adolescence, girls tend have the habit of being less active than boys. So that could be one explanation. But we at least us couldn't find any other study about sarcopenia in this population, but that could be one of the reasons.
Yeah, I see. Yeah. I don't know how it is also, well, at least I didn't mention it to find it in the literature during treatment. So this is probably a striking finding. Yeah, but interesting. Yeah. Well, people are thanking you for your nice presentation. And please feel free to ask questions if they are still there. I'll just wait a few seconds. But otherwise, we can close the session earlier as well. I think it was very nice to hear all the work you've done already and planning to do so. And also, like, for this educational sessions we have every month, it's nice to have a kind of other perspective on the importance of physical activity. I think we, as nutritionists or dietitians, we do know, and of course we also try to take it into account in our studies, but like from your side, we learned a lot more about the importance of lean mass and bone mineral density for the survivors, and the same is true for children during treatment, I guess. But it was very nice to learn from all your work. So thanks for sharing and for all the good work. Yes, and with that, I would like to end the session. Thanks again for your presentation. This session is video recorded, so Saib will share it as well with the community. Well, have a nice morning, afternoon, or evening for all the people who are with us.
Thank you very much.
Once again.
Have a good one. Bye bye.